Good afternoon and welcome. My name is Donna Cryer. I am the founder and CEO of the Global Liver Institute, and I have the privilege of being your host on this episode of GLI Live. Spring has sprung, even though where I am in Washington, D.C., it's a little bit of a rainy day. But as more people are getting COVID vaccines, even my mom, as of 30 minutes ago, hope springs eternal, and it looks like there's a light at the end of this pandemic tunnel. But as we think about emerging from quarantine cocoons, many of us realize that we're a little heavier than when this pandemic started, and may want to do something about it. But it's more than just vanity. And so this episode is entitled Why Weight Can't Wait, and why you might want to put an extra bit of urgency around your attention to weight and weight issues for you and your family and your communities. And with us, I have the foremost expert, really just my bucket list, if I could have asked the universe, which I guess I did, of who I would have wanted to talk about this topic. My wishes were granted. And so I have with us today Dr. William Dietz, who is director of the Sumner M Redstone Global Center for Prevention and Wellness at the Milken Institute School of Public Health, and also director of the STOP Obesity Alliance at the GW University. And so, Dr. Dietz, welcome.
Thank you, Donna. It's a pleasure to be here, and thank you for that glowing introduction.
It is heartfelt. I have been watching and reading your work for a long time, and it was one of the key factors why when we launched our GLI NASH Council in 2017, wanted to do it at the Milken Institute School of Public Health. One, I was hoping to attract your attendance, and two, I wanted to make sure that NASH was from the very beginning positioned and perceived as a public health issue. But you've been working on these issues around weight, obesity, nutrition, and far before 2017. So please tell us how it became your life's work and passion.
Well, that's a lengthy story, and I'll try and make it short. The bottom line is that I ended up working on obesity because I couldn't work on undernutrition in the developing world. I had spent the summer of my third year of medical school in rural Guatemala in a clinic, and was really intrigued by the association of undernutrition, infection, and immunity, and had been doing some research on that as a medical student, and wanted to go back to Latin America and set up the state-of-the-art lab to study those responses and perhaps to use nutritional status as an index of immune function. But my family had other ideas. So when I was in graduate school at MIT, I shifted to the issue of obesity, which has many parallels with undernutrition in terms of the social determinants and the intricacies of the metabolic interactions. So that was my course. That was the origin of my interest. And at the time, there were only 3 people in the country working on childhood obesity, and so it was a wide open playing field. And everywhere I turned, there was a question that nobody had answered right on the pediatric side. So it became a very rich opportunity to look at the interactions of epidemiology, clinical medicine, and metabolic responses, which turned out to characterize a good part of my career.
And now there are many more than 3 people doing work on childhood obesity, because unfortunately, the rates of childhood obesity have just been skyrocketing. What in our environment or genetics, is driving that trend, particularly for children, and driving the development of complex serious diseases like NASH even?
Well, I think the answer is everything. That we can't isolate an individual cause for the most part, and even the genetics are not terribly helpful. We certainly understand that genetics are important, but genetics affect susceptibility. And susceptibility is acted upon by an environment that has reduced physical activity and increased the promotion of food and consumption of foods, many of which are ultra-processed foods, which we now know make a significant contribution to obesity. The other thing that is essential is that obesity doesn't act equitably across populations. There are very significant ethnic and racial differences in the prevalence of obesity, particularly among women, less so among men. But African American women have the highest prevalence, followed by Hispanic women, who are not terribly different than white women. And the source of those disparities, I think, has to be understood in terms of structural racism, the kind of access to food and the access to safe opportunities for physical activity. And Donna, I know you're familiar with the DC, the DC alignment here, and the fact that wards 7 and 8 contain about 250,000 people and only have 3 grocery stores to feed that population. And so people that live in that part of the district are reliant on corner stores for much of their food supply, at least pre-COVID, and well, probably post-COVID as well. And those foods tend to be high in salt, sugar, and fat. They have a long shelf life. They're tasty. So what's not to like about them? Because they're less expensive than fruits and vegetables, and they don't spoil. And so we can't really talk about the inequities associated with obesity without thinking about the structural racism that has characterized this country for 500 years.
I think that's absolutely true. I'm equidistant between multiple Whole Foods, and until recently could walk to a gym that had a swimming pool, and as well as everything else, and the location of both healthy food sources and safe places to exercise certainly magnified during a pandemic. Many people can't just order Instacart. They are the Instacart shoppers themselves, and hoping that someone will pay and tip high enough so that they can go back and choose the healthy foods for themselves and their families the way they spend all day choosing for other people.
Well, that's true. The essential workforce is not treated as though it's essential.
Right. So as we've started to dig into some of the barriers that your Stop Obesity Alliance and your Weight Can't Wait campaign are unearthing. Tell us more about those structural or policy or other barriers to people achieving a healthy weight, so that everybody listening, as well as across the Global Liver Institute, can help you knock down those barriers.
Well, we'd welcome the support, that's for sure. So the work that we've done at the Stop Obesity Alliance has focused on how to improve the care of patients with obesity, of people with obesity. A project that grew out of the Roundtable on Obesity Solutions at the National Academy of Medicine developed a series of competencies for obesity providers. And we're not just talking about physicians, but also nurse practitioners, physician assistants, OBGYNs. That the competencies were things that every provider ought to have. We also looked at what the attitudes were and practices were of primary care providers, and this included, on the adult side, the family practitioners, internal medicine docs, OBGYNs, and nurses. And it turns out that they didn't know very much about the recommendations for obesity. So that began to set the stage for what we needed to do. We knew that reimbursement was a big problem and a barrier to obesity care, and we looked at state programs, state health plans for their employees, and also state Medicaid programs and their obesity coverage, which was very limited. And for example, one state had recommended only one episode of counseling for obesity care, which is crazy. Because obesity is a chronic disease and needed to be treated as a chronic disease. We've also looked at as the Weight Can't Wait guide as an important contribution to primary care providers about how to open the conversation. A major challenge is that obesity is a highly stigmatized problem. It's up there with race in many cases, and that just opening the conversation is very awkward for providers. And so the Weight Can't Wait guide offers a dialogue, the opportunity for a dialogue around weight, which begins with, what is your greatest concern about your weight? What are the barriers to weight loss? What have you tried to do? What do you think you can do? Rather than the way many providers treat obesity, which is, oh, you just, you have a weight problem, or in fact, they will say you're obese, which is a pejorative term and causes a reaction among patients. And then go on to say, well, all you need to do is to eat better and exercise more. Well, that's crazy. What patient doesn't know that, and how many patients with obesity have already tried that 20 or more times? And so a real emphasis in the Weight Can't Wait guide is on treating people with obesity respectfully, asking them whether they want to be measured, or if they're ready to have a conversation about weight, and if they are, to make sure that the decisions are shared, that they're not imposed in a hierarchical way by the provider, but rather decisions that are taken in collaboration with the patient. And then we go on from that to make sure that there's an appointment that follows that, because if a provider brings obesity to the attention of a patient, the patient is much more likely to initiate weight loss efforts and more likely to succeed. But many times, even after that occurs within a clinic, that is effective counseling occurs within a clinic, no follow-up is scheduled. And that's really a gap. At this point, we're not really, I think, expecting primary care providers to manage obesity, although that's the long-term goal. And part of the problem there is that I don't think that there's sufficient awareness that obesity is a disease, that it's a chronic disease. And as long as obesity is perceived as a behavioral problem with individuals responsible for their weight, the focus is going to be on behavior modification. Whereas if obesity is considered a disease, then providers may begin with behavior change, which is important, but are much more likely, we think, to use medication. And there's now an emerging number of medications that look as though they're going to be as effective as bariatric surgery in the treatment of obesity. But getting there and changing the perception of providers and also changing the perception of patients about their responsibility is a big lift. I think many patients have accepted this notion that they're responsible for their own obesity. Whereas in fact, obesity is, as I mentioned earlier, is this complicated interaction of individual susceptibility and environment. And that's patients, because they feel responsible, are less likely to demand effective therapy, or less likely or reluctant to think about medications.
Many, I'm sure, don't even know that they exist. Not the crazy stuff you see advertised at late nights, or that are harmful or dangerous supplements, but real FDA approved medications with studies and results that are designed as part of a whole program.
Right.
You talked about stigma. I think for our patients with NASH, and even more so, with patients of color with NASH, you now packing stigmas on top of stigmas. So, the stigma of living with overweight, the stigma of having a liver disease, which is, huge, and sort of what HIV was, several years ago. And, going back to explaining to your family, like, I don't drink, I didn't use drugs. There is just, something metabolically, genetically within me that we're still trying to research and explore. But I have this now series of conditions, and for people who are trying to wrap their minds around, I have a liver disease. I might also have type 2 diabetes. I have excess weight. I might have high cholesterol as well. It can be very daunting. How can we best support people in seeing it, and their physicians, and seeing it as an opportunity to get all of those factors, improved and moving in the right direction, and really delivering sort of whole person care. I feel, so strongly that, NASH provides us a unique opportunity, perhaps a tipping factor for people who have been struggling with weight loss for many years, but when shown the damage, unfortunately, to their liver, or something that they may have never contemplated or had a doctor discuss with them, maybe that's the thing that is the extra, motivation. How can we best construct and support, whole person care for people to be successful in modifying, all the factors that they can, and ensuring that they have access to sort of every supportive tool at every stage. So if it is more than one counseling session, or access to a dietitian, or access to bariatric, and understanding the different balloon and other options, weight loss medications, and just really, how can we help put the pieces together for people in a more coordinated fashion that's easier for them to access, wrap their minds around, and involve their families.
Well, I think that stigma and bias walk hand in hand with the lack of recognition of obesity as a disease, which in turn is a challenge for providers who are not trained in obesity care, who are not familiar with even how to open the conversation. And that's really been the focus of the STOP Obesity Alliance, is providing those tools, making it easier for providers. And a lot of that begins really when a patient walks into the waiting room, and how that patient is greeted, and whether the waiting room has chairs that accommodate people of increased body weight, whether they're weighed in a private setting, and how that weight is communicated, and whether they're even asked permission to be weighed. Many patients are embarrassed by that, or have had, and actually the most stigmatizing people in the field of obesity are family members and providers. About 75% of patients with obesity have said that the most stigmatizing experiences they've had are with family or with providers. So patients come in to a clinic with real wariness, and many have avoided care because of their experiences with providers who are insensitive to the whole issue of obesity. And so I think that starting with awareness and respect, and understanding of the burdens that people with obesity carry, and the kinds of experiences they've had as a result of the stigmatization, is where this conversation has to start. Many people, despite how prevalent obesity is, many people have never had a conversation with a person about their weight, and about the kind of challenges their weight has posed. And Obesity Action Coalition has been really a terrific group in providing space for people to tell their stories and to share them, particularly with groups like medical students or physician assistants who need to hear these stories.
I had a physician, ask me, in one of our work groups, someone who of very good intent, but he was asking, well, what if the patient, doesn't think of themselves as overweight, and doesn't, think they need to lose weight? They were trying to wrap their mind about, entering a conversation or a relationship from that point.
Well, if the first question that a provider asks is, "Are you concerned about your weight?" that opens up the next series of questions.
Oh.
Well, if the patient says no, then I think it's the provider's responsibility to say, well, as I look at your record, your blood pressure is elevated. You have elevated lipids. These are attributable to your weight, and I understand that you may not be ready to work on this.
Mm-hmm.
But I wanted to let you know that obesity is a serious medical condition, and that when you're ready, I'm happy to help you with this problem.
I think that's fantastic. I think that will probably be taken and will help so many people. It's certainly, as I talk to some of our partners who are doing various mobile imaging and community programs around the world in NASH, showing that image of the fat accumulation in the liver and using that as a jumping off point, saying, we're going to just give you the information. If you want to do something about it, we're here, to support that. But we want you to have all the information about what is going on in your body. And I think that sort of fact-based, evidence-based, leaving the control with the person is absolutely the way to go. Mm-hmm. I often say about shared decision making, I'm like, it's always been shared decision making. Sometimes we share our decision with the doctor.
Yeah. Well, the other, I think it bears saying that the other significant source of bias is the media. Mm-hmm. And how many times do you see an image of a person with obesity who is headless or legless? It's guts and butts, that suggests that people with obesity are dehumanized. They're not real people. And there's a real effort on the part of a number of groups to, when you're talking about obesity or showing something about obesity, to use an image of a person with obesity, a mm-hmm. full active person. Right. So from head to foot, mm-hmm. Which I think changes the perception of a person with obesity.
Representation matters, and as much as we've had, the success of, I'll just use the term because that's how it originated, plus size models, mm-hmm. Who are more the average size of everybody than sort of a size 2 or sample size model. But with those campaigns and Dove campaigns and other brands promoting models and Instagram influencers of size and substance. I hope that helped give a broader range, but it often goes so much deeper, and it's I think in those perhaps everyday representations of not just the supermodel, but the athlete and the yoga person, the attorney, the accountant, in all walks of life, being respected and being and being supported, and so that issue of representation is important.
Yeah, it's been interesting to watch the Athleta ads, which include people with obesity, mm-hmm. and showing them active as they are and should be.
So, so being at a certain BMI itself is not necessarily the issue, but these metabolic markers and or issues of impact on joint health or liver health or what have you. Do we know sort of at what point it crosses over, or sort of really what sets of informations we do need to have conversations with people that your weight is starting to impact your health? When is it fine to be thick, and when is it starting to be problematic, and how can we help people identify that point?
Well, part of the answer is metabolic, and part of the answer is personal. The personal part is when obesity becomes a concern to the person. The metabolic is a little bit different because, as you point out, part of it is related to the trajectory.
Mm-hmm.
BMI is not a perfect measure. It's not a measure of fat. And we know that there's a fair amount of misclassification of people in the overweight category, a BMI of 25 to 29.9. On the other hand, body weights that are above a BMI of 30 are usually characterized, invariably characterized by excess body fat.
Mm-hmm.
And then the issue becomes, well, where is that fat deposited? And we know that abdominal or visceral fat is a much more hazardous fat depot than fat in the lower extremities. And the adipose tissue, the cells are quite different. The cells that are intra-abdominal are much more active than the ones in the buttocks or thigh. And that relates directly to the complications associated with obesity. I think that any of those complications at a BMI of, in terms of the actual recommendations, BMI of 27 with an existing complication or a BMI of 30 and above are recommended targets for interventions.
And for some communities, for Asian and Asian American communities, those thresholds are a little lower, correct?
Right. Yes, and you don't see that in the data that the National Health and Nutrition Examination Survey published, because they use the Western standards of BMI of 25 and 30, whereas for Asian Americans and Asians in general, the standards are 23 and 27 for overweight and obesity.
Okay, so we want to make sure that we're giving accurate information to all of our community members. I want to talk about, certainly before we leave, about the impact of obesity on COVID severity and mortality, and the extra risks that it poses to people with obesity, and the urgency around vaccinating people with BMI over 30, as well as, of course, with liver disease, cirrhosis, transplant, kidney disease, and diabetes as well. But there's been so much very well done work on the intersection of COVID and obesity that I wanted to give you some time to talk about that a bit.
Sure. Well, it's an important question, and one which the pandemic has really brought to the fore. The three major risk factors are age, and that's not something we can do very much about, but people over the age of 75 are at greatest risk for obesity. Race, we know that African Americans and Hispanics have a greater risk of infection, hospitalization, acute care needing the ICU and ventilation than other patients, and people with obesity. And there is overlap between people with obesity and race, although I haven't seen a really good analysis of that. But on the positive side, we have a paper that we've been working on that looks at the effect of physical activity on immune responsiveness. And it appears as though physical activity is protective against certain infections, upper respiratory infections. There are no data yet related to COVID-19. But it does look as though if you're physically active, at least in the literature, you have some protection against the severity of COVID-19 infections. The other thing, which is complicated,
making me invincible, just like they.
Yeah, maybe. The other thing that's important to point out that we know is, well, there are two things. One is that with the lockdown, people have been reliant on ultra-processed foods and are less active. And there is a growing body of data suggesting that we're gaining a lot of weight because of that lockdown. An article in the Times quoted somebody as saying that it was about 2 pounds a month of weight gain. A study in a Midwestern city, a really good study, that has looked at kids on Medicaid in the first quarter of 2020 and the third quarter of 2020 indicated a very substantial weight gain and also a very marked increase in the prevalence of obesity. So the effects of COVID-19 on obesity are kind of self-perpetuating. You gain weight, you're more susceptible to an adverse course of obesity. And the food insecurity that's accompanied this pandemic also has contributed to obesity. We know that there is a relationship, at least on the adult side, there seems to be a relationship between food insecurity and obesity, which makes sense because if you're food insecure, you're likely to eat more when food is abundant and to compensate for the time when food is less available. So I've called the COVID-19 obesity and food insecurity syndemic. These are 3 pandemics occurring simultaneously, and each has an adverse effect on the other. That's fed by the essential workforce that we were talking about earlier, who are front lines and often have poor diets, may have obesity, certainly, and we know in the processing plants, they didn't have personal protective equipment. Nursing homes were the same. And these are the essential workforce, which tends to be overrepresented by Hispanics and Blacks. So we have a self-perpetuating system that is really built on structural racism, both at the food processing end as well as the food consumption end.
We are talking with members of Congress over the course of the day with the American Association for the Study of Liver Diseases and advocates from around the country on the Social Determinants of Health Act, amongst other key pieces of legislation. We've worked, of course, with you on TROA to make sure that there are all the elements of obesity care management, and the American Rescue Plan. I think all pieces to allow us to really look holistically at how can we improve people's health and wellness, from their homes, their families, their communities, their workplaces, their schoolyards, what they have available to eat in their community, how they can, be facilitated to safely move in their communities. And then, if they do have excess weight, how are they supported in their physicians' offices with covered services so that they can be of optimal health? Perhaps it's because I have both, GI and liver diseases, or, now have multiple chronic conditions. But, my inclination is to want to tie things together and to coordinate them and not go sort of organ by organ or condition by condition, but really think how care can be delivered in the context of someone's life, in a way that can help them be successful. And I really applaud your work and approach to provide the tools for people to do that.
Well, thank you. And thank you for the opportunity to have this conversation with you. I think that you're so right that liver disease is one of the while it's increasingly better recognized, but 5 or 10 years ago, nobody was paying any attention to it and its association with obesity.
Well, 5 or 10 years ago, we didn't exist. So here we are. Thank you so much. So thank you to everybody who's listening to my fabulous conversation with Dr. Bill Dietz, a member of the National Academy of Medicine. You referenced that. I find, body without, but you're so too humble to mention that you are a member of the esteemed Academy. Amongst your many other awards, titles, and accolades. But we're just so grateful that you're applying all of your expertise and passion to these issues. Thank you so much for today.
Well, thank you, Donna. Thanks for the opportunity. And we so admire the work that you're doing. So thank you.
Excellent. So until next time, everyone, you can find this episode and others on Facebook, Twitter, and on our website, globalliver.org. And you see our various handles at Global Liver across the internet. Thank you so much, everybody. Have a great day. Be well.